Welcome to the Introduction to Intellectual and Developmental Disability Nursing. This educational presentation is brought to you by the DDA Health Initiative of Georgetown University Center for Child and Human Development. This project is funded by the DC Department on Disability Services. Much has changed from the time that nurses were first involved in the care of people with disabilities in segregated state-run institutions that were often in sites that were very far away from the community, where people were removed from their family, and in fact there were often times when family members were told to forget their family member. Siblings may not have known that they had a brother or a sister with a disability, and it was certainly a time that was not anything that people are particularly proud of today. But it's important to know the history of where we have been and where we are coming to. In the 1920s, institutions were seen as improvements. They were seen as opportunities for people with intellectual disabilities to receive training. They would receive nurturing. Again, the idea of the time was that this was in the best interest of the girl or boy who happened to have an intellectual disability. As we move forward, we now know and we look back that there were really many abuses that occurred in institutions. Our way of thinking today is completely different. We don't see a need to remove people from their families. So much has changed. One of the things that is difficult now for nurses as we try to develop a professionalism around this type of specialized nursing in developmental disabilities is, where do we go for the models? How do we understand what our role is? This module will get into some of that information, and we have some subsequent modules that will look specifically at the scope and standard of practice that's been established by professional organizations. Now we'd like you to click on the link to the Beyond Forest Haven video. This is a video that was developed in collaboration with the University Center for Excellence in Developmental Disabilities at Georgetown, the ARC of DC, the Quality Trust, and it begins to tell the story of Harold and Betty Evans as the lead people who filed a class action suit in 1971 demanding appropriate services. I hope you will enjoy this very thought-provoking video. Certainly one thing that has changed over time is the terminology. The very words that we use to describe people who happen to have an intellectual disability has evolved from words that we now clearly see as demeaning. But at one point, I was in the medical literature to refer to people with intellectual disabilities as idiots, imbeciles, feeble-minded, mentally deficient, and in fact professional organizations also had adopted this terminology. In the 1960s, mental retardation was considered a respectful term, but over time that term also became something used in a very derogative fashion. In 2008, the professional organization of the American Association on Intellectual and Developmental Disabilities put forth the term intellectual disabilities, and this is the term that is widely used today. In fact, as you review some of your health records, your other records in the agency in which you work, pay attention. Some physicians and some therapists are still using outdated terminology. If you see that, you should bring it to people's attention so that it can be corrected going forward. You want to be a good example as a professional nurse to other people that are working on the support team, so that if you hear the term, the R word, as people with disabilities will say, the term retard or retardation used in any type of a derogatory way, people need to be educated about it, that it's disrespectful. Now, anytime we talk about what we call people first language, so for example, instead of saying the disabled person, as you often read in newspaper accounts, the respectful people first language would be the person with a disability. Now, as all things related to culture or values or preferences, there are some people with disabilities themselves who say they really don't pay attention to that, and they may refer to themselves as being disabled. People who belong to a certain movement of people with autism will say autism is a very important part of who we are, and we refer to ourselves as autistics. As a person without a disability, I would recommend that you stick to the people first language, because we are not the people who experience that disability firsthand, and it would be preferable to use the people first language. Another terminology that you're going to hear a lot about is the concept of person-centered planning or person-centered thinking. There's a whole body of work on this. In fact, there is training that is available on all the concepts of person-centered thinking, on tools to use in your planning, and I would suggest that you avail yourself to this training. But in brief, person-centered planning refers to putting the person with disability, the person who is going to receive the services and supports, at the center of the planning, and that we learn about the person, we learn about their preferences, we learn about what they want. This concept is starting to come into the health field, and physicians and nurses in hospitals and other medical settings are starting to see the value of meeting the person where they are and really trying to work on the things that are important to them. So person-centered planning is part of what should be incorporated within your nursing assessment and within your nursing planning. And then the fourth principle here is the idea of community integration. Community integration, again, quite a distinct view apart from where we came from institutional settings, but community integration is something that we keep moving the bar on, and what perhaps used to be considered a community integrated setting, for example, a day program that was in the community, not at the institution, is today now we're rethinking that also, and we're looking at, well, where do people without disabilities spend their day? People without disabilities are employed, or if they're not employed full-time, they are attending concerts, they are shopping, they are going to the library, they are exercising, really pushing the envelope about full participation in the community. And so too, as you assist the person in accessing healthcare resources, you want to think about what can you do as the professional nurse to help educate other healthcare providers to learn about and be comfortable in supporting someone with an intellectual disability so that they can access their healthcare in the most integrated environment. Now we'll take a look at the term developmental disability. This is actually a definition that is codified within federal law, and it refers to a condition that is severe, chronic, and one that is attributable to either a mental or physical disability. The disability must be manifested before the age of 22. So for example, someone who may not be able to walk, who is immobile due to cerebral palsy that was identified shortly after birth, has a developmental disability. Another person who is also immobile and may need assistance in all their activities of daily living, but that immobility is a result of a cerebrovascular accident that occurred at the age of 50, does not meet the criteria for a developmental disability. The disability is also one that is likely to continue indefinitely. So we are not referring to any type of short-term illness, no matter how serious the illness may be, it is one expected to continue indefinitely. So for example, a child who may have a brain tumor and who had extensive surgery but is expected to recover from that experience would not be considered as having a developmental disability. A developmental disability is also one that results in substantial functional limitations in the major life activities. And major life activities include the ability to care for yourself, the ability to receive and express communication, and economic self-sufficiency. It also reflects the need for the person to require special interdisciplinary services, requiring individualized supports or other forms of lifelong assistance that are individually planned and coordinated. Next, we will look at the definition of intellectual disability. Intellectual disability is one example of a developmental disability. And as defined by the American Association on Intellectual and Developmental Disabilities, intellectual disability represents significant limitations both in intellectual functioning and adaptive behavior. The intellectual disability must originate before the age of 18. It is demonstrated in IQ testing, but also in adaptive behavior testing. It is not just one or the other. And the person's disability has to be considered within the context of the person's environment. It's very important to make sure that, for example, the person is tested in their dominant language, that consideration of a child's exposure to multiple languages is taken into consideration. A child's physical impairments need to be considered, and how, for example, cerebral palsy may impact on the child's ability to speak, and so therefore using an IQ test that does not rely on a person's ability to speak in order to present the information to the testing psychologist. So all of this constellation of information is what has to be considered before an intellectual disability diagnosis is given. It's important to remember that in the District of Columbia, primary eligibility for services under the Developmental Disability Administration is the presence of an intellectual disability. Healthcare provided by a registered nurse did not exist in institutional settings until the 1930s and 1940s. Prior to that time, care was simply custodial, barely meeting, in most instances, barely meeting people's needs to be adequately fed and clothed and cared for. If you recall in the Beyond Forest Haven video, the pictures, the images there from the institution, by and large, showed people who were emaciated, people who were not completely dressed, people whose hygiene was not to acceptable standards. And in the early periods of nursing role in the institutions, it would be barely what we even consider direct support professionals to conduct today. The big change really came in the early 1960s with the emphasis that President Kennedy's administration gave to this subject area. In large part, it was influenced certainly by his sister, who had an intellectual disability, but also by the very strong advocacy of his sister, Eunice Shriver, who really pushed her brother, President Kennedy, to develop legislation that established programs at that time that were called university-affiliated facilities in 12 university centers across the United States. We're proud that here at Georgetown University, we were among one of those first 12 university centers. And as part of those centers, an early role for the centers was the development of diagnostic clinics, where families could turn to receive comprehensive evaluation of their children, and not simply an explanation of, well, they have an intellectual disability. Of course, they weren't using that terminology then, and not really looking at sophisticated ways in which the children could be supported. This led to the development of the university-affiliated facilities, led to the development of research centers designated to people with intellectual disabilities. And for a while, a lot of the federal legislation focused on particular disability states. It was later in the late 70s, early 80s, where that more umbrella term of developmental disabilities came into play, and we began looking at how the person functioned within their environment and the extent of supports that they needed. So as nurses began working in institutions, and there were some wonderful examples from the 70s and 80s of nurses who were really developing a very strong professional role for the registered nurse, utilizing fully the nursing process. Nurses also were part of developmental diagnostic clinics, oftentimes going into the home to evaluate the child's ability to interact in familiar environments. As schools began to have a formal responsibility for the education of children with disabilities, school nurses, public health nurses assumed a bigger role, again, in how the child, supporting the child to function optimally within the school setting. And as states began to close all their institutions, like we did here in the District of Columbia, or closing many of the large state-run facilities, nurses continued to expand their role in community health services. And today, and the role that you are about to assume, is one that is going to be very well integrated within the community, a role that you will be expected to advocate to be sure that the man or woman for whom you are providing health supports is accessing all of the supports that they should based on their age and gender, based on best practices. So your assessment, your planning, your education of the other staff, education of the person to the extent possible so that they can learn and take charge of their own health issues and prevent health problems will be very important. And we certainly can see the changes that have happened just looking at the median survival age. In the 1950s, the person with Down syndrome wasn't expected to survive much more than past the age of 25 years. In 1997, we're seeing that survival increased to 59 years, and now the median survival rates continue to increase as infants are receiving better care in the prenatal and postnatal period. Of course, the advent of antibiotics and really exquisite care when there are cardiac complications. In fact, it leads to an increase in the rate that we see in people with Down syndrome of having dementia. Earlier, I referenced the inception of university-affiliated facilities during President Kennedy's administration. Those centers also have evolved and have some new terminology, and they are now referred to as University Centers for Excellence in Developmental Disabilities. There is at least one in every state and territory. Georgetown University continues to be the designated USED for the District of Columbia. And our authorization comes from the Federal Developmental Disabilities Act that also authorizes two other entities that as a professional nurse supporting people with intellectual disabilities, it's important for you to understand this constellation of resources in the community. So in addition to the USED, there's also a Developmental Disability State Planning Council. The chair of this council is appointed by the mayor's boards and commission, and there are members on that planning council that represent people with disabilities, family members, government organizations, and other advocacy organizations. There's also, a third arm is the Protection and Advocacy Agency here in the District of Columbia. That is University Legal Services. And they certainly carry on a monitoring role, but more importantly, they do conduct legal advocacy. They take on some specific cases, but their most important function is on a broader scale of how they look at advocacy in legislation, the development of legislation, the development of policy, looking at housing needs, etc. And then, of course, the University Center for Excellence in Developmental Disability that has three primary responsibilities: training and technical assistance, research and evaluation, and information dissemination. And all three of those components are embodied in our DDA Health Initiative, and I welcome you to go to our website to learn more about the training that we offer and other information. I would like to now begin to focus and look at you as the professional nurse. You are coming into developmental disability nursing perhaps from a completely different role. You may have spent your career up to this point in a hospital setting, in a long-term care setting, in a psychiatric setting, or perhaps you were working on behalf of people with developmental disabilities in another state, or maybe had some work as a consultant, but may not have really had the opportunity to really think through all of the elements of your practice. Certainly the nursing process is the same whatever setting you find yourself in. The important critical thinking skills in the assessment, determining outcomes, planning, developing a plan of care, implementing that plan of care, and then evaluating it. Of course, I think one of the really big differences in the specialty of developmental disability nursing is that you are going to be working with a cadre of people on the support team, including the person with disability, to assess the situation and also the determination of outcomes. What is important to that person, what is important for that person. In planning your care, you're going to have to remember that that care oftentimes will be delegated to a direct support professional or a qualified developmental disability professional who will in fact do most of the implementation. And then going back to evaluate, are you getting the outcomes that you initially intended? What needs to be modified in order to get to those outcomes? Or perhaps the outcomes that you initially derived weren't realistic. So the care that you will provide is determined by a set of nursing practice standards. We will have a module that focuses exclusively on the standards for intellectual and developmental disability nursing. But right now, I would like to have you turn to the handout on the phenomena of concern for nurses. This is something that was developed in 2004 in collaboration with the American Nursing Association and the Professional Association for Intellectual and Developmental Disabilities. The phenomena of concern here is divided into three primary areas: concerns for the individual, looking at the family context, and looking at the community. So let's take a look at people with disabilities. Again, why do they have a disability? Because they do have some unique anatomical features. They may have a unique physiology, someone who has a particular genetic syndrome, certainly psychological differences as evidenced by their cognitive limitations, and how they may have co-occurring mental health diagnoses as well. We're looking, however, at interventions that really promote function, especially in an adult. We are looking at how can they best engage in their community. So it will not be unusual, for example, to see an adult who may ambulate with some assistance in their home, but if they want to be out and go to the mall or go and visit a museum for an afternoon, they're going to use a wheelchair because the wheelchair is going to be able to help them function better in that community environment. A lot of your effort is going to be on the prevention of secondary impairment. So for people who are immobile, the skin assessment is so important, understanding positioning, prevention of pneumonia due to aspiration. So again, the importance of assessing how the person is handling food and fluids. How is that person positioned? Does the staff understand the signs of dysphagia and what they should do about it? Here in the District of Columbia, we put a lot of emphasis on making sure that people are receiving appropriate primary health care, and that includes adult immunizations. How are acute and chronic illnesses managed? Again, what can we teach the person with the intellectual disability to know about their own bodies? What do we need to teach the direct support professionals who are the people who are usually with them 24 hours a day? How are we collaborating? You as the registered nurse are part of a team of people where the person with disability is really at the center and should be at the helm. The teaching that needs to be done for that person's level. One of the reasons that is hypothesized that there are significant health disparities experienced by people with intellectual disabilities is because they never are able to take advantage of any health teaching that is appropriate to their literacy and to their receptive abilities. We want to look at care of the whole person. It is not just about the health management. Yes, that is very important, but it's also important to live a life that is meaningful for that person. And how does their health intersect and support that? There are lots of planning, and depending on the person's age, there are all kinds of different plans. Here in your work with DDA, it will be focused on the individual support plan, of which the healthcare management plan developed by the registered nurse is a part of that overall individual support plan. Advocacy. You need to be strong advocates. First of all, you need to advocate for the person and their point of view. You need to advocate for your role as a registered nurse and your knowledge of a registered nurse and how that influences the other therapists or physicians that you're working with. You need to be aware of legal issues. There are legal issues, particularly in terms of consent, making sure that there is appropriate consent received, legal issues related to end-of-life planning, and then the importance of respecting the cultural, religious, and family views of that person, and certainly the cultural and linguistic experiences of the direct support professionals and other people on the team are going to play a very important role in how effective you're going to be able to be in your care planning, and also needs to be taken into consideration in terms of communicating. Looking at the family, I like to think about people with disabilities and their family as often being interdependent, but again, remembering, because we are working in a system that serves adults, we have to remember that there are times, perhaps, when the interests of the adult may run contrary to the wishes of the family, and you may play an important role in helping to sort some of this out. This often happens around issues of independence. Is the person able to independently take their medication? Are they able to independently travel? Are they able to engage in the sexuality practices that they prefer? It's going to require continuous collaboration with the family to help sort those issues out, to educate people, to help them think through some of these challenging issues. And then looking at the community, again, where the person lives, how the person interacts with members of the community is so important. And really keeping abreast as the professional nurse of changes that occur. Right now, there are massive changes that are coming from the federal Centers for Medicare and Medicaid Services that are going to greatly influence how we look at services and supports in the community. CMS has put forth criteria on what it means to provide services in the community. This isn't something that is for other people on the team to think about. As the professional nurse, you also have an obligation to stay abreast of these issues. I would encourage you to become a member of a professional organization such as the American Association on Intellectual and Developmental Disability Nursing or the Developmental Disability Nursing Association. The registered nurse needs to demonstrate the leadership skills, to be confident of your assessment, of your findings, and be able to communicate that in a collaborative manner. I hope that you will always retain your eagerness to be a learner, to always learn new things. We are learning new things in healthcare, of course, all the time. Information about people with disabilities is improving all the time. Use everything that is at your disposal. Use the resource people that are at DDA. Use Google. Learn how to use Google and how to discern what are the scientific articles versus something in the popular literature. Admit when you don't know something, especially if you're new to this setting. Put yourself in a learning mode. It may sound contradictory. I'm asking you to be a leader and be a learner, but I don't see those two things as mutually exclusive. If you don't know something, get back to that person, and once you do, find the information that you need. You'll be participating in interdisciplinary service meetings. Be well prepared. We will spend some time in a subsequent module talking about the nursing assessment and planning process. That is that information, your assessment. What do you think is critical for this person? How does that fit in with the findings of other people on the support team? Looking at how will a chronic illness, if a chronic illness is present, how will that impact their daily life, expectations for the future. So all of the skills that you have developed in your nursing education, in other areas of practice, will come to good use in this setting. The professional nurse working in a setting that supports people with intellectual and developmental disabilities wears many hats, has many roles. First and foremost is that of the clinician. Your exquisite nursing skills are required. Your exquisite assessment, planning, teaching, communicating skills are all very important. If you like to teach, this is the place for you, because there is so much teaching that needs to happen. Teaching for the person that you're supporting who has a disability, but also teaching other members of the team on your healthcare management plans. Every intervention that you deem essential to that person's health has to be taught to the direct support professionals. They have to be taught the observation skills. They have to be able to demonstrate competency in performing certain tasks, perhaps implementing someone's mealtime protocol or positioning protocol. You have to go back. It's not just teaching them one time, because you have to go back and see, have they retained the things that you taught them. When someone comes back from a hospitalization, You may be teaching some new observation skills particular to what brought that person to the hospital in the first place. You're going to be a member of an interdisciplinary team. So this means not only being aware of what you do in your discipline of nursing, but learning how do other disciplines function in this setting, reading the reports of the other disciplines, reading that speech-language pathologist report, the physical therapist report. If you see something in their report that is contradictory to your assessment, drawing that to their attention and having a conversation about it so that you are using each of your perspectives to the maximum benefit of the person with a disability. While we have service coordinators that are employed by DDA, and you also will be working with qualified developmental disability professionals, you also, though, have some role in case managing. You want to make sure that if it is the QDDP that is taking care of the maintenance of adaptive equipment and ordering of adaptive equipment, for example, that is happening. You can't just come in and see someone whose wheelchair is in need of repair and simply presume that someone else is taking care of it. What do you know about what has been done about that? Because all of these things impact the overall health care of the person for which you're responsible. You have to be an advocate. We've mentioned this a couple of times, and I will emphasize it again. You need to be an advocate within your own support team. You may need to be called upon to be an advocate in the wider community, in a hospital setting, for example, to make sure that you are advocating that people are properly assessed for pain relief, that people are being properly turned in position to prevent a pressure ulcer. You don't want to wait until the person is discharged with a stage 2 or 3 pressure ulcer. You're going to be a counselor. You're going to be offering counseling to the person with disability, perhaps, in particular if you are working with someone who has a dual diagnosis. And sometimes you might find yourself as a counselor to the direct support professionals. I certainly firmly believe that in providing end-of-life care, there comes a point where the nurse's focus in the residential setting really does turn to the support staff to make sure that they have the spiritual support, the practical support of recognizing that this may be the first time, for example, that they've ever been with someone at the time of their death. And so your professional counseling skills will be important. You'll be called in as a consultant. What is your role, particularly if you have any administrative function, in consulting with the executive director or other administrators of your agency to help them understand the work that needs to be done? If you are supporting people in a home who have increasing support needs because of age or the development of chronic illness, helping the administrators to understand the role that the nurses play and perhaps the need to look at different staffing ratios, etc. You certainly will be an administrator. You know, how are you even going to get to the different sites that you need to get to? Delegating your role, certain roles, to other people on the team so that you are available to conduct and to act in the highest capacity of which you are prepared to practice. And then this last role of researcher gets really very little attention, but I think that is something that I'd like you to think about. Collecting data simply on how are your patients doing, and we don't typically use that term, but how are the people that you're supporting doing? You're developing stated expected health outcomes as part of your healthcare management plan. What percentage of the people who you support who have hypertension, for example, stay within their ideal range of blood pressure? How many people have you helped to support to lose and get to their ideal body weight? Collecting data on outcomes can certainly be very important to demonstrate the quality that your service agency can deliver. Very important in recruiting new people coming into your agency. I think it's important to help your members of your interdisciplinary team recognize that, you know what, we're doing a really good job, or, hey, we need to do better in another area. Let's figure out how we're going to get there. And then certainly some of you who may be thinking about advancing your education and developing some research skills. So think of yourself as a researcher, whether you are doing formal research that involves institutional review boards and special funding, or simply really the evaluation of your nursing practice. When you sit back and look at your nursing practice, perhaps at the end of your first 2 months of employment or during an annual performance evaluation, can you answer these questions? Is your practice collaborative? Are you seen as an important member of the team who offers good professional information, who's easy to work with? Is your work comprehensive? Are you thinking ahead of the simple day-to-day exams or demands? Are you planning ahead? Are you working to make sure that services and supports are coordinated in a way that really contributes to the quality of life for people with disabilities? Are you learning about cultural and linguistic competence? What do you know about your own culture? How does your culture and your language experience affect the people you support? How do they affect the people you work with? How do they affect family members? Have you done as much as you can to really employ the principles of person-centered thinking? Are you incorporating the elements of what is important for the person and what is important to the person within your planning and evaluation? How are the interventions that you recommend supporting inclusion in the community? Are you looking, for example, for ways to help someone manage their weight that brings them into a Weight Watchers class, or brings them to an exercise class that's held at the local church a block away from their home or apartment? And again, that emphasis on work, looking back at what has the person with a disability identified during their annual planning process as something that's important to them. Is a paid employment important for them? Is volunteer work important for them? And then your role as a nurse, how are any health issues affecting that that may need to be ameliorated or may need to be identified and supported during the work day and also outside of work in community recreation and community enjoyment? So this constellation of principles are really very important, yes, on a day-to-day basis, but sometimes, again, I would encourage you to sit back and look, am I hitting all of these points? I hope you found this first learning module helpful as setting a foundation, looking at the historical perspective of the role of nurses in support of people with developmental disabilities, looking how services and supports to people with disabilities have evolved over time, as has the practice of nursing, looking at some of the guiding principles and understanding the important functions, how the nurse interacts with other members of the support team, the nurse's role in supporting and focusing on the expressed desires and preferences of the person with disability. I certainly hope that you are going to enjoy this practice of nursing, this specialization, and I welcome you to review the other 3 modules that we have prepared to take you into more specific information about the practice of nursing in support of people with intellectual and developmental disabilities.